Okay, let's unpack this. We are diving into, well, a monumental topic today. Drugs for diabetes.
Absolutely. It's huge.
And our mission isn't just to, skim the surface of blood sugar management. It's really to move past the flashcards.
Right.
We want to help you achieve that comprehensive understanding, the true mastery that, frankly, sets elite professionals apart in this field.
That's exactly the goal. We're aiming to cut through the noise, focus really intensely on the mechanisms of action, the subtle differences in pharmacokinetics, and crucially, the specific clinical constraints. The things that actually dictate prescription choices day to day.
We want to give you that kind of clinical cheat sheet almost, the knowledge that turns dense info into applied, high-stakes decision-making.
Exactly. Applied knowledge.
And the urgency here is just undeniable. The scale of this disease is staggering. 30.3 million people in the U.S.?
Yeah, and 422 million globally. It's a massive public health challenge.
So this deep dive, it really has to begin at the source of the problem, the pancreas. And its whole hormonal control system.
Yeah, right. The regulatory center is the islets of Langerhans. It's this cluster of specialized cells right there in the pancreas.
Okay.
And you've got three main peptide hormones working there to keep glucose balanced. Homeostasis.
Key players.
The beta cells, they generate insulin. The alpha cells produce glucagon. That's insulin's counter-regulatory hormone. Basically does the opposite.
Right, raises blood sugar.
And then the delta cells produce somatostatin, which kind of dampens the action of both insulin and glucagon. It's a regulator.
So a really delicate system.
Very delicate.
Okay.
And when this system fails, which is, the definition of diabetes mellitus, you end up with either a relative or an absolute lack of effective insulin.
And the result?
Chronic, serious hyperglycemia, high blood sugar.
And if that state is just left unchecked, untreated, the sources warn us about long-term devastation. We're not just talking feeling unwell.
No, far from it. We're talking irreversible microvascular damage, retinopathy in the eyes, potentially blindness.
Nephropathy, leading to kidney failure.
Exactly. And painful neuropathy, nerve damage. Plus, on top of all that, massive cardiovascular complications, heart attack, stroke, which are often what prove fatal.
So the stakes for getting the therapy right couldn't be higher.
Absolutely critical.
Okay, let's frame this discussion using the four major clinical classifications from the American Diabetes Association.
Right.
The ADA. We've got type 1, type 2, gestational diabetes.
Right, during pregnancy.
And then diabetes due to other causes like genetics or maybe specific medications.
Correct. But the real clinical challenge, where most of the focus lies, truly crystallizes when we contrast the two main types, type 1 versus type 2.
Yeah, understanding that difference is fundamental, isn't it?
It's foundational to any treatment strategy. So type 1 diabetes is the minority, maybe 5% to 10% of cases.
Okay.
It's usually caused by autoimmune destruction of those vital beta cells, often presents pretty suddenly childhood or adolescence.
And these patients, characteristically, they're often undernourished when diagnosed.
That's right, because their body is literally breaking down fat and muscle for energy since it can't use glucose properly without insulin.
So the system breakdown is, well, total in type 1. The source material really emphasizes that losing beta cell function means two specific physiological failures happening at once.
Exactly. First, they can't maintain that low, steady background level of insulin, the basal insulin.
Which is needed 247.
Right, needed all the time to suppress those baseline catabolic processes. Things like lipolysis, fat breakdown, proteolysis, muscle breakdown, and glycogenolysis, which is releasing stored glucose from the liver.
Okay, so that's the first failure. What's the second?
Second, and critically, they absolutely cannot respond to the big surge of glucose that comes after a meal. The prandial response is gone.
Makes sense.
And without that basal insulin, those catabolic processes we mentioned, they run rampant. That leads straight to dangerous diabetic ketoacidosis, or DKA, if treatment is missed even for a short time.
Wow. So the treatment goal is pretty uncompromising then.
It has to be. It's 100% replacement with exogenous insulin from outside the body. The aims are clear. Control hyperglycemia, avoid DKA, and maintain the HbA1c.
That's the marker for average blood glucose over the last, 3 months?
Exactly. Keep that HbA1c below target levels, usually around 7% or less, depending on the individual.
Okay. Now, type 2 diabetes, that's the vast majority, right? 90 to 95% of cases?
The overwhelming majority. It usually presents later in life, typically over age 35, and it's highly linked to, well, modern lifestyle factors.
Like genetics, getting older.
And significantly obesity. That's a major driver. But the pathology here, what's actually going wrong, is fundamentally different from type 1.
How so?
Type 2 is defined by peripheral insulin resistance. Basically, the body's tissues, primarily muscle, liver, fat, they just stop responding effectively to the insulin that is being produced.
So the insulin is there, but the locks on the doors have changed,
Yeah.
kind of?
That's a good analogy. The pancreas initially tries to overcome this resistance by pumping out more insulin. You actually see hyperinsulinemia, high insulin levels early on.
Oh, okay.
But eventually, the beta cells just can't keep up with that high demand. They get exhausted, and their function becomes insufficient. Importantly, it's not absent like in type 1, just not enough.
And critically, these patients, they're usually not ketotic at the start.
Rarely. Because they still have some endogenous insulin floating around, enough to prevent that catastrophic fat breakdown, that lipolysis that leads to DKA.
Okay, the distinction is really important. And the treatment path reflects this difference too, right? It's more progressive.
Absolutely. For type 2, we usually start with lifestyle changes, diet, exercise, weight reduction, all aimed at combating that underlying insulin resistance.
Makes sense. Improve sensitivity first.
Exactly. But the typical trajectory, and this is shown well in figure 24.5 in the source, it's often a slow but steady path, from lifestyle changes to oral agents. And eventually, most people with type 2 will require insulin therapy as that remaining beta cell mass gradually and sort of inevitably declines over time.
So it's not a failure of the initial treatment necessarily, it's the disease progressing.
Precisely. That progression means a successful regimen requires continuous monitoring and, really, a willingness from both the patient and the clinician to escalate therapy as needed. It's never a static treatment plan for type 2.
Okay, that sets the stage perfectly. Let's turn our attention now to the core of replacement therapy. Insulin itself and all the modern analogs we have, starting right at the beginning, the biochemistry. It's a polypeptide hormone.
Yeah, two chains, A and B, connected by disulfide bonds. It's synthesized first as a precursor molecule called proinsulin.
Okay.
Then enzymes cleave that proinsulin to produce the active insulin molecule and also a fragment called C-peptide.
And that C-peptide, measuring it, is actually really useful clinically, right? It's one of those key insights for professionals.
It's incredibly useful. You see, insulin itself gets rapidly extracted and metabolized by the liver and kidneys as it passes through. So measuring insulin levels in the blood can be a bit misleading about how much the pancreas is actually producing.
Ah, I see.
But C-peptide is co-secreted in a 1-to-1 molar ratio with insulin, and it's not significantly cleared by the liver. So measuring C-peptide gives you a much better, more stable index of the body's endogenous insulin production.
So it tells the clinician exactly how much the patient's own beta cells are still contributing.
Precisely. It helps distinguish, for example, between late-stage type 2, where production is low, and maybe someone factitiously injecting insulin.
Fascinating. Okay, let's get into the mechanism. How does the pancreas manage that elegant chemical dance of actually releasing insulin? Walk us through the steps inside the beta cell from, say, a rise in blood sugar to that burst of insulin release.
Okay, it's this really neat electrical and chemical cascade, sometimes called pulsatile exocytosis. It all starts when blood glucose levels rise after a meal, for instance. Glucose enters the beta cell through specific transporters, GLUT transporters.
Right.
The immediate gatekeeper, the real glucose sensor inside the cell, is an enzyme called glucokinase.
Glucokinase, got it.
Glucokinase phosphorylates the incoming glucose, essentially traps it inside the cell and starts its metabolism. This metabolic step rapidly generates ATP, the cell's energy currency, so it directly links glucose availability to the cell's energy status.
So the high ATP concentration, that's the critical internal signal.
That's the key intracellular signal, yes. This high ATP then binds to and blocks these crucial channels on the beta cell membrane called ATP-sensitive potassium channels, or KATP channels.
Okay, blocks potassium from leaving.
Exactly. And because positively charged potassium ions are blocked from flowing out, the electrical charge across the cell membrane starts to change. It becomes less negative inside, it depolarizes.
And that depolarization, that's the electrical trigger that opens up different channels.
That's right. It triggers the opening of voltage-gated calcium channels. When those open, calcium ions, C8+, rush into the cell from the outside.
Okay.
And the surge in intracellular calcium is the final signal. It triggers the fusion of the insulin-containing granules with the cell membrane and their release, that pulsatile exocytosis of insulin into the bloodstream.
Wow. So glucokinase is the sensor, K-ATP channels as the immediate electrical switch, calcium as the final trigger.
You got it. And understanding that K-ATP channel step is absolutely non-negotiable for understanding how some of the oral diabetes drugs, the secretagogues, actually work later on. They target that channel.
Excellent. Okay, moving to the practical side. Pharmacokinetics and delivery. Since insulin's a polypeptide, you can't take it orally, right? Stomach acid would just destroy it.
Correct. It has to be given parenterally. Subcutaneous injection SC just under the skin is the standard route for routine management.
But there are other options too.
Oh yeah. For emergencies like severe hyperglycemia or DKA, we use regular insulin given intravenously, IV, for a very rapid effect. And for daily management, especially for people needing tight control or more flexibility, there's the insulin pump, continuous subcutaneous insulin infusion, or CSII.
How does that work exactly?
The pump delivers a continuous low basal rate of rapid-acting insulin 24/7. Then, the patient manually delivers larger boluses doses right before meals or to correct high blood sugar readings. It offers really precise control.
And there's an inhaled version too.
There is, yes, a dry powder formulation of rapid-acting insulin. But as we'll discuss, its use is quite restricted due to potential lung issues.
Right. And a lot of the modern variation comes from tweaking the insulin molecule itself, modifying the amino acid sequence to create these analogs.
Exactly. Analogs like insulin lispro, aspart, glulisine, glargine, detamir, degludec, they're all engineered to change the absorption rate from the injection site. This fundamentally alters their onset of action, their peak effect time, and their duration.
Which lets you tailor the insulin profile much more closely to the patient's needs, mimicking both basal and mealtime insulin.
That's the goal. Tailoring is vital. But before we get into the specific types, we absolutely have to talk about the risks.
Agreed. What's the biggest concern?
Across all insulin regimens, the most serious and by far the most common adverse reaction is hypoglycemia, low blood sugar.
Yeah, that's the big one.
Clinicians have to spend a lot of time educating patients on recognizing the signs: tachycardia, fast heart rate, confusion, sweating, shakiness, dizziness.
And how to treat it quickly with fast-acting carbs.
Absolutely. And managing chronic effects, too, like weight gain, which is common with improved glucose control.
Yeah.
And also lipodystrophy.
What's lipodystrophy?
It's localized changes in the subcutaneous fat tissue at injection sites. You can get either atrophy, a hollowing out, or hypertrophy, a thickening. It can affect insulin absorption.
How do you minimize that?
Meticulously rotating injection sites, not using the exact same spot over and over again.
Makes sense. And back to that inhaled insulin restriction, why is it so limited?
Because there's a significant risk of bronchospasm, especially in people with underlying lung conditions. So it is strictly contraindicated, absolutely cannot be used in patients with asthma, COPD, or active smokers. That really limits its utility.
Okay, got it. So let's break down the different insulin preparations. The sources categorize them based on onset, peak, and duration. This is key for deciding how to use them.
Exactly. This dictates their role in a regimen.
First up, the rapid-acting insulins. You mentioned Lispro, Aspart, glulisine, and the inhaled form fits here too.
Yes. These are analogs chemically modified for very quick absorption from the subcutaneous tissue. They start working within minutes, maybe 15 minutes or so.
And they peak quickly.
Yeah. Peak effect is usually within a tight window, maybe 30 to 90 minutes after injection. And their duration is relatively short, maybe 3 to 5 hours total.
So they mimic that immediate burst of insulin the pancreas would normally release right after you eat.
Precisely. That makes them essential for prandial dosing covering meals. They're usually administered right before a meal, say 0 to 15 minutes before starting to eat, sometimes even up to 15-20 minutes after starting.
And they're the standard choice for insulin pumps.
Yes, because of that predictable, rapid effect and short duration, they worked very well for both the continuous basal infusion and the mealtime boluses delivered by a pump.
Okay, next category, short-acting insulin. This is basically just regular insulin, right?
Correct. Regular human insulin, often formulated with zinc to form soluble crystals. It's absorbed a bit slower than the rapid-acting analogs.
So when do you take it relative to a meal?
Its onset is slower, maybe 30 minutes, so it needs to be injected about 30 minutes before meal to match the glucose rise. Its peak is also slightly delayed, maybe 50 to 120 minutes, and it lasts a bit longer, maybe 5 to 8 hours.
And as you noted, this is still the standard formulation for IV use in emergencies.
That's right. When you need intravenous insulin, regular is the one.
Okay, moving on to intermediate-acting insulin. This is NPH, right? Neutral protamine Hagedorn, or isophene insulin.
Yes. NPH is essentially Regular insulin that's been complexed with zinc and a protein called protamine. This makes the complex much less soluble at physiological pH.
That means.
It significantly delays its absorption from the subcutaneous tissue, gives it a longer onset, maybe 1-2 hours, a broader peak around 4-8 hours, and a duration of about 10-18 hours.
So what's NPH used for?
It's used strictly for basal or fasting glucose control. It provides background insulin coverage between meals and overnight. Often, it's given once or twice a day, maybe combined with rapid or short-acting insulin injections to cover meals.
And a key point here, NPH must only be given subcutaneously, never IV.
Absolutely critical. It's a suspension. It contains protamine. It's not suitable for IV use or for emergency management where you need rapid, predictable action.
Got it. Finally, the real foundational insulins for basal coverage. The long-acting basal products, glargine, datamir, and degludec.
These are the modern workhorses for providing a steady, reliable background insulin level. They are specifically engineered to provide a flat, prolonged effect, ideally over 24 hours or close to it.
And like NPH, these must only be administered SC.
Only SC. And crucially, they must never be mixed in the same syringe with other insulins. Mixing can change their pH or formulation and completely alter their absorption profile and duration. You lose that predictable long action.
Okay. And they achieve that long, flat profile through different chemical tricks, right?
Exactly. Really clever chemical engineering. Insulin glargine, for instance, has amino acid changes that lower its isoelectric point. This means that when it's injected into the neutral pH of the subcutaneous tissue, it instantly precipitates out of solution.
Forms little depots.
Sort of, yeah. It forms these microprecipitates that then slowly dissolve and release insulin monomers over an extended period, often around 24 hours. This gives it that characteristic flat, peakless effect profile.
Interesting. What about detamir?
Detamir achieves its longevity differently. It has a fatty acid side chain attached to one of the amino acids. This fatty acid allows detamir molecules to bind reversibly but strongly to albumin, both in the subcutaneous tissue and in the bloodstream.
So it kind of hitches a ride on albumin.
Pretty much. And the slow dissociation from albumin governs its prolonged duration of action, typically up to 24 hours, depending on the dose.
And degludec, that's the ultra-long one.
That's the longest acting one we have. Insulin degludec is engineered to form these stable multi-hexamer chains when injected subcutaneously. These chains then slowly release insulin monomers over a very long period.
How long?
Its half-life is over 25 hours, and its duration of action extends well beyond 24 hours, providing a very stable, flat basal coverage, sometimes allowing for more flexibility in injection timing.
Okay, that covers the main types. Now, when putting together a regimen, clinicians often talk about standard versus intensive therapy. What's the difference?
Intensive therapy aims for a much tighter glucose control. The goal is typically a mean blood glucose of 154 mg/dL or less, which corresponds to an HbA1c of 7% or lower.
And how is that achieved?
It usually involves multiple daily injections, 3 or more, often using a basal insulin plus rapid-acting insulin before each meal, basal bolus regimen, or using an insulin pump. It also requires frequent blood glucose monitoring by the patient, maybe 4 or more times a day.
And the benefit. The sources say it significantly reduces microvascular complications.
That's the major finding from landmark trials like the DCCT in type 1. Intensive therapy significantly reduces the long-term risk of retinopathy, nephropathy, and neuropathy compared to less intensive standard therapy.
But there's a big trade-off, isn't there?
A huge trade-off, and the sources are very clear on this. Intensive therapy comes with a 3-fold higher frequency of severe adverse events.
3-fold higher? What kind of events?
Severe hypoglycemic episodes lows requiring assistance from another person, as well as coma and seizures resulting from profound hypoglycemia.
Wow, that's a staggering increase in risk. Clinically, how do you even manage that? And who absolutely should not be on this kind of intensive, potentially dangerous path?
That risk profile means intensive therapy is flatly contraindicated, just not appropriate for certain vulnerable populations.
Such as?
Patients with very long-standing diabetes, where the potential benefit in preventing complications might be less and the risks higher. Also, patients of advanced age who might be more susceptible to falls or cognitive issues during hypoglycemia.
And crucially?
Critically, patients who experience hypoglycemic unawareness. This is a dangerous condition where the body loses its ability to generate the usual warning symptoms of low blood sugar, the sweating, shakiness, palpitations.
So they can become severely hypoglycemic without realizing it.
Exactly, which dramatically increases the risk of severe episodes, coma, or accidents. Intensive therapy is generally avoided in these individuals because the risk just outweighs the potential long-term benefit. You have to prioritize immediate safety.
Okay, that's a really crucial set of contraindications. We've covered the core insulin products in detail, but as you alluded to, a big shift in modern therapy isn't just about optimizing insulin. It's also about using other injectable treatments, often leveraging the gut-pancreas connection.
Absolutely. This brings us first to pramlintide, which is a synthetic amylin analog.
Amylin, what's that?
Amylin is another peptide hormone that the beta cells normally co-secrete right alongside insulin, particularly after you eat.
Okay, so it works with insulin.
It does. Pramlintide mimics its function, and amylin basically acts as a set of physiological brakes on the whole digestive and glucose absorption process.
What are those breaks? What does it actually do?
It has three main functions. First, it delays gastric emptying, which slows down the rate at which glucose from your meal hits the bloodstream. Smoother post-meal profile.
One.
Second, it decreases postprandial glucagon secretion. Remember, glucagon raises blood sugar. Amylin helps stop the liver from inappropriately dumping more sugar into the blood right after you've eaten.
Right, suppresses the counter hormone too.
And third, it enhances satiety, the feeling of fullness. This can help with appetite control and potentially weight management.
So pramlintide is used as an adjunct, an add-on to mealtime insulin
Yeah.
for both type 1 and type 2.
Yes, for patients using mealtime insulin who still aren't achieving their glucose goals. But there's a crucial administration note here, absolutely vital for patient safety.
What's that?
Because pramlintide works synergistically with insulin to lower post-meal glucose, when you initiate pramlintide therapy, the dose of the rapid or short-acting mealtime insulin must be decreased, usually by about 50%.
50%. Why so much?
To mitigate the significantly increased risk of severe hypoglycemia that happens when you combine these two powerful postprandial glucose-lowering agents, if you don't cut the insulin dose, the risk of dangerous lows is very high, especially initially.
Okay, that's a critical safety point. Mandatory dose reduction.
Mandatory. And its mechanism of delaying stomach emptying also means it's contraindicated in patients who already have diabetic gastroparesis, slowed stomach emptying due to nerve damage. Using it there could make things much worse.
Vicious cycle.
Exactly. Also contraindicated if someone has hypersensitivity to cresol, a preservative in the formulation, or if they have hypoglycemic unawareness. And one more practical point. Pramlintide cannot be mixed in the same syringe as insulin because they are chemically incompatible. Separate injections are needed.
Got it. Okay, moving from amylin mimics to probably the biggest game-changing class of injectables. The GLP-1 receptor agonists, also known as incretin mimetics.
Yeah, these have really transformed type 2 diabetes management in many ways. The entire class relies on understanding this fascinating physiological phenomenon called the incretin effect.
The incretin effect, explain that for us.
Okay, it's pure physiological insight based on a simple observation. If you give a person glucose orally by mouth, it causes a much higher secretion of insulin than giving the exact same amount of glucose intravenously straight into the vein.
Huh. Why is that?
Because when glucose passes through the gut, the intestinal cells release these hormones called incretins. The two main ones are GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide.
Okay.
These incretin hormones travel through the blood to the pancreas and significantly boost insulin secretion in response to the glucose. In fact, this incretin effect is responsible for a whopping 60% to 70% of the body's normal insulin secretion after a meal.
Wow, that much.
That much. It's a major physiological amplifier. But here's the kicker for diabetes. This natural incretin effect is significantly blunted or reduced in people with type 2 diabetes.
So they lose that natural post-meal boost.
Exactly. So the drugs in this class, you've got albiglutide, dulaglutide, exenatide, liraglutide, lixisenatide, semaglutide. They are all polypeptides designed to mimic or enhance the action of GLP-1, essentially restoring that lost incretin signal.
Makes sense. They're receptor agonists.
Yeah.
And what does activating that GLP-1 receptor do? What's the mechanism?
It's wonderfully multi-targeted, which is why they're so beneficial clinically. First, they improve glucose-dependent insulin secretion.
Glucose-dependent, meaning?
Meaning they primarily stimulate insulin release only when blood glucose levels are high. When glucose is normal or low, their effect on insulin secretion is minimal. This is a huge advantage because it means they have a much lower intrinsic risk of causing hypoglycemia compared to drugs like sulfonylureas.
That's a major safety benefit. What else?
They also slow gastric emptying, similar to amylin, which helps control post-meal glucose spikes. They enhance satiety, often leading to desirable weight loss, which is another major benefit in type 2 diabetes where obesity is common.
Weight loss is a big plus.
Huge plus. They also suppress the inappropriate release of glucagon after meals, further helping control hyperglycemia. And there's even some evidence, mostly from preclinical studies, that they might promote beta cell proliferation and survival, although the clinical significance of that in humans is still being studied.
Okay, multiple beneficial actions. What about how they're given? Pharmacokinetics.
This is where we see some variety, offering flexibility in dosing. They are all injectable, as they're polypeptides. You have some that are dosed once daily, like liraglutide and lixisenatide.
Okay.
And then you have the convenience of once-weekly injections for agents like albiglutide, dulaglutide, semaglutide, and also an extended-release formulation of exenatide. That weekly dosing is really attractive for adherence.
Definitely. Any specific pharmacokinetic issues to note, like with kidney function?
Yes, exenatide, particularly the original twice-daily formulation, requires caution and dose adjustment in moderate renal impairment and should generally be avoided in patients with severe renal impairment, CRCL 30 mLN. The others generally have fewer issues with mild to moderate kidney disease, but always check specific prescribing info.
Good point. What about side effects? You mentioned benefits, but what are the downsides?
The most common adverse effects are gastrointestinal nausea, sometimes vomiting, diarrhea. These are often most pronounced when starting the drug or increasing the dose, and they tend to lessen over time for many patients.
So patient coaching is important there.
Very important for managing expectations and adherence. On the more serious warning side, there's been an association observed between GLP-1 agonists and pancreatitis. Although a direct causal link is debated, they should generally be avoided in patients with a history of chronic pancreatitis.
Okay, pancreatitis risk. Anything else major?
Yes, there's that significant black box warning, primarily associated with the longer-acting agents in this class. It stems from findings in rodent studies where these drugs caused an increase in thyroid C-cell tumors, including medullary thyroid carcinoma, MTC.
Thyroid cancer in rodents. Does that translate to humans?
The relevance to humans is still uncertain and being monitored. However, because of this potential risk, these agents are strictly contraindicated in patients who have a personal or family history of MTC, or in patients with multiple endocrine neoplasia syndrome type 2, MEN2, which is a genetic syndrome that predisposes to MTC.
Okay, another critical contraindication to screen for.
Absolutely. But balancing these risks is the major clinical benefit that has really shifted treatment algorithms, especially for patients with existing heart disease.
The cardiovascular protection.
Exactly. Several large cardiovascular outcomes trials have been done. Liraglutide and semaglutide, both injectable and now oral forms, and dulaglutide have demonstrated significant reductions in major adverse cardiovascular events. MACE, things like heart attack, stroke, cardiovascular death in patients with type 2 diabetes and established cardiovascular disease or high CV risk.
So they're not just lowering sugar, they're actively protecting the heart and vessels.
Precisely. And liraglutide, for example, specifically gained an FDA indication not just for glucose control, but for actively reducing the risk of ME. This places cardiovascular benefit right alongside glucose lowering when selecting a second-line agent after metformin, especially in high-risk patients. Empagliflozin, an SGLT2 inhibitor we'll discuss later, also shares this benefit.
That's a huge paradigm shift. Okay, we've covered insulin and the adjunct injectables. Now let's transition to the cornerstone of type 2 management for many, many patients, the oral agents.
Right, the pills. These agents tend to work best, generally speaking, for type 2 patients who are diagnosed after age 40 and have had diabetes for less than about 5 years, suggesting they still have some residual beta cell function.
And there are a lot of classes here. We need to master, what, 10 different classes? Starting with the oldest ones, the insulin secretagogues.
Exactly. The sulfonylureas, or SUs, are the classic example here. You've got glyburide, also called glibenclamide elsewhere, glipizide, and glimepiride.
These are the original players, really. How do they work?
Their mechanism is direct and quite effective. Remember that K-ATP channel we talked about in the beta cell, the one blocked by ATP?
Yeah, the electrical switch.
Sulfonylureas essentially bypass the need for high ATP. They bind directly to a specific protein associated with that K-ATP channel and force it closed.
Ah, so they directly trigger the channel closure.
Yes. They directly block potassium outflow, which forces the cell membrane to depolarize, opens the calcium channels, lets calcium rush in, and triggers insulin release. They basically hotwire the insulin secretion process.
But because they force insulin release, whether blood sugar is high or low.
Exactly. That leads directly to their major side effect profile. Hypoglycemia is a significant risk. They can also cause weight gain, partly due to the increased insulin levels, hyperinsulinemia, and maybe people eating more to avoid lows.
And there's a critical clinical danger zone with these drugs, right? Related to how they're cleared.
Yes, drug accumulation. Most SICUs are metabolized by the liver and/or excreted by the kidneys. So in patients with significant hepatic, liver, or renal kidney insufficiency, the drug's half-life can be dramatically prolonged,
Meaning it hangs around longer and keeps forcing insulin release.
leading to prolonged, severe, and potentially dangerous hypoglycemia. The sources specifically highlight that glyburide, which has active metabolites that are renally cleared, carries the highest risk of this prolonged hypoglycemia in patients with renal impairment.
So glyburide is generally avoided in kidney disease.
Generally, yes, or used with extreme caution. Glipizide or glympuride, which have less active or inactive metabolites or different clearance pathways, are considered safer alternatives in patients with renal insufficiency and also often preferred in the elderly who are more vulnerable to hypoglycemia.
Good distinction. And drug interactions are a big deal here too.
Definitely. Certain drugs can reduce their effect, things like corticosteroids, thiazide diuretics, some thyroid hormones, potentially leading to loss of glucose control.
And others can potentiate them.
Yes, and this is often more dangerous. Drugs like NSAIDs, certain antifungals like ozoles, some antibiotics, sulfonamides, and importantly, non-selective beta blockers, which can mask hypoglycemia symptoms and potentially enhance insulin release, can all increase the glucose-lowering effect and drastically raise the risk of hypoglycemia. You have to be really vigilant about concomitant medications.
Okay. Related to the sulfonylureas, there's another class of secretagogues,
Yeah.
the glucagonide, repaglinide, and netaglinide.
Right. They are also insulin secretagogues working through that same KATP channel mechanism, but they bind to a slightly different site on the channel complex than the SUs do.
What's the key difference in how they act?
Their main differentiating feature is their pharmacokinetic profile. They have a very rapid onset of action and a much shorter duration compared to most SUs.
Rapid on, rapid off. So what does that make them good for?
It makes them particularly effective as postprandial glucose regulators. They're designed to be taken immediately before a meal, maybe 15-30 minutes prior. They provide a quick burst of insulin to cover the glucose load from that meal, and then their effect wears off relatively quickly, which might reduce the risk of hypoglycemia between meals compared to longer-acting SUs.
Okay, targeted mealtime insulin release, important cautions.
Yes. Because they have a similar mechanism to SUs, closing the KATP channel, they should never be used in combination with a sulfonylurea. There's no added benefit, and the risk of severe hypoglycemia would be additive and unacceptably high.
Makes sense. Don't double up on the same mechanism.
Exactly. Also, repaglinide specifically has a warning against concurrent use with the lipid-lowering drug gemfibrozil. Gemfibrozil inhibits the liver enzyme, CYP2C8, that metabolizes repaglinide, leading to much higher repaglinide levels and increased risk of severe hypoglycemia. That combination is contraindicated. Netaglinide doesn't seem to have this specific interaction.
Good, specific interaction to remember. Okay, moving from drugs that make the body release more insulin, let's talk about the undisputed champion of initial type 2 therapy, the biguanides, which is basically just metformin, right?
That's right. Metformin is in a class of its own, the biguanides. And the American Diabetes Association, ADA, and other major guidelines consistently recommend metformin as the preferred initial oral drug for virtually all patients with type 2 diabetes, assuming they don't have any contraindications.
Why is it so preferred? It doesn't cause hypoglycemia when used alone.
That's a major advantage, yes. When used as monotherapy, metformin does not cause hypoglycemia. It works primarily as an insulin sensitizer, but its main mechanism is quite different from other sensitizers.
What is that primary mechanism?
Its primary and most significant effect is reducing hepatic gluconeogenesis. Basically, it tells the liver to produce less glucose, especially during the fasting state. Since excessive glucose production by the liver is a major contributor to high fasting blood sugar in type 2 diabetes, this is a key target.
Okay, turns down the liver's sugar factory. But the modern understanding goes a bit deeper now, doesn't it? Something about AMPK.
Indeed. Metformin's action is now strongly linked to the activation of an enzyme called AMP-activated protein kinase. AMPK, within liver cells and other tissues.
AMPK, what does that do?
AMPK acts like a cellular energy sensor. When activated, as metformin does, it signals a state of low energy. This triggers downstream effects that include suppressing the genes involved in gluconeogenesis in the liver and also promoting glucose uptake into peripheral tissues like muscle. So it improves insulin sensitivity indirectly, too.
Fascinating. It sort of tricks the cells into acting like they're energy depleted.
That's a reasonable way to think about it. And importantly, unlike many other diabetes drugs, metformin is generally weight neutral or can even be associated with modest weight loss, which is another significant benefit for many type 2 patients.
Okay, major benefits. What about the downsides? Adverse effects?
The most common side effects are gastrointestinal, diarrhea, nausea, abdominal discomfort. These are very common, especially when starting the drug, and often dose-limiting. Starting with a low dose and titrating up slowly and taking it with meals can help mitigate these.
But there's a rare but very serious risk associated with metformin.
Yes. The most feared, though thankfully rare, adverse effect is lactic acidosis. This is a potentially fatal metabolic complication where lactate builds up in the blood.
And this risk dictates the main contraindications.
Absolutely. The risk of lactic acidosis is significantly increased in conditions that predispose to lactate accumulation or poor clearance. Therefore, metformin is contraindicated in patients with severe renal dysfunction, usually defined by an estimated glomerular filtration rate, eGFR, below 30 lmin 1.73 mil2, because the kidneys clear metformin. It should also be used with caution or dose adjusted in moderate renal impairment, eGFR 30-45.
Okay, severe kidney disease is a definite no-go. What else?
It should also be temporarily stopped in situations that can cause acute kidney injury or tissue hypoxia, such as acute myocardial infarction, heart attack, sepsis, severe infection, acute decompensated heart failure, or during procedures requiring intravenous iodinated contrast dye, like certain CT scans, as the contrast can temporarily impair kidney function. You typically hold metformin before the procedure and restart it 48 hours later after checking renal function.
Lots of critical stop situations. Anything else to monitor?
Yes, long-term metformin use can interfere with the absorption of vitamin B12 in the gut, potentially leading to deficiency over time, which can cause anemia or neurological symptoms. So periodic monitoring of B12 levels is recommended, especially in patients on long-term therapy or those with risk factors.
Okay, metformin. Highly effective, first line, but with crucial GI side effects and strict contraindications related to kidney function and acute illness due to lactic acidosis risk. Got it.
That's the summary.
All right, let's move on to another class of insulin sensitizers, the thiazolidinediones, or TZDs. The main ones here are pioglitazone and rosiglitazone.
Correct. These also improve insulin sensitivity, making the body's tissues respond better to insulin, but they work through a completely different mechanism than metformin. And like metformin, they generally don't cause hypoglycemia when used alone.
Okay, different mechanism. How do TZDs work?
The TZD mechanism is fundamentally genomic. They act as agonists activators for a nuclear receptor called PPAR gamma, peroxisome proliferator activated receptor gamma.
PPAR gamma, that sounds complicated. What does activating it do?
PPAR gamma is found mainly in adipose, fat tissue, but also in muscle and liver cells. When a TZD binds to and activates PPAR gamma, it acts like a transcription factor. It goes into the cell nucleus and changes the expression of a whole suite of genes involved in insulin signaling, glucose metabolism, and lipid metabolism.
So it reprograms the cells in a way.
Essentially, yes. It particularly affects fat cells, promoting their differentiation and increasing their capacity to store fatty acids safely. This is thought to reduce the spillover of toxic lipid metabolites into muscle and liver, a process called lipotoxicity, which is a major contributor to insulin resistance. They also directly enhance insulin signaling pathways in muscle and liver.
So a very upstream fundamental mechanism targeting insulin resistance.
Exactly. It's an elegant mechanism. However, despite this, the safety profile of TZDs has been quite challenging and has limited their use significantly.
What are the main safety concerns?
Historically, liver toxicity was a concern, particularly with the first TZD, troglitazone, which was withdrawn. While pioglitazone and rosiglitazone have a much lower risk, periodic monitoring of liver function tests, LFTs, is still generally recommended.
Okay, liver monitoring. What else?
The most critical and class-defining adverse effect is fluid retention and resulting peripheral edema, swelling, and weight gain.
Fluid retention. Why is that such a big deal?
Because this fluid retention can precipitate or significantly exacerbate heart failure. Therefore, TZDs are absolutely contraindicated in patients with established New York Heart Association, NYHA, class 3 or FE, heart failure, basically, severe heart failure. They should be used with extreme caution, even in milder heart failure.
Okay, heart failure is a major red flag for TZDs. Any other significant warnings?
Yes, several studies have shown an increased risk of bone fractures, particularly in the distal limbs, hands, feet, of women taking TZDs. The mechanism isn't fully clear, but it seems related to effects on bone metabolism. So risk of osteopenia and fractures is another concern.
Fractures, too. And there are specific safety distinctions between the two main TZDs still available.
Yes. Pioglitazone use has been associated with a small potential increase in the risk of bladder cancer, based on some observational studies, although the data is somewhat conflicting. This requires discussion with patients, especially those with a history of bladder cancer or risk factors.
Okay, pioglitazone and bladder cancer risk. What about rosiglitazone?
Rosiglitazone has had a more troubled history regarding cardiovascular safety. It carries a persistent boxed warning regarding a potential increased risk of myocardial infarction, heart attack, and angina based on meta-analyses of earlier trials. While later large trials didn't definitively confirm this risk, its use remains restricted compared to pioglitazone due to these lingering concerns.
So TZ is elegant mechanism targeting insulin resistance via PPAR gamma, but significant baggage with fluid retention, heart failure, fracture risk, and specific concerns about bladder cancer, PO, and possibly MI, ROSI.
That sums it up well. Their use has declined considerably because of these issues and the availability of newer agents with better safety profiles or added benefits.
Okay, next class, the alpha-glucosidase inhibitors, acarbose and miglitol. These seem quite different. They work entirely in the gut.
Exactly. These are purely GI tract drugs. They don't affect insulin secretion or sensitivity directly. Their mechanism is to reversibly inhibit enzymes in the brush border of the small intestine enzymes like sucrase, maltase, and alpha amylase.
The enzymes that break down complex carbohydrates.
Precisely. By inhibiting these enzymes, they delay the digestion and absorption of complex carbohydrates, like starches and sucrose, further down the intestine. This effectively slows down the influx of glucose into the bloodstream after a meal, lowering those postprandial glucose peaks.
Okay, flattening the after-meal spike. Is there a unique clinical point we absolutely need to know about these?
Yeah. Yes, there's one critical piece of information you must remember if using these agents. If a patient taking an alpha-glucosidase inhibitor develops hypoglycemia, usually because they are also taking an insulin secretagogue or insulin, you must treat that hypoglycemia with pure glucose, dextrose, like glucose tablets or gel.
Not with sucrose, like table sugar or regular soda. Why not?
Because these drugs specifically inhibit sucrase, the enzyme needed to break down sucrose into glucose and fructose. So if you give sucrose, the patient won't be able to absorb the glucose component effectively to treat the low. You need to give monosaccharides like glucose directly.
That is a crucial, potentially life-saving detail. Good to know.
Absolutely vital. Unfortunately, the clinical use of alpha-glucosidase inhibitors is significantly limited by their side effect profile, which is directly related to their mechanism.
What kind of side effects?
Because carbohydrates reach the lower intestine undigested, they get fermented by gut bacteria. This commonly causes significant flatulence, diarrhea, and abdominal cramping and bloating. These GI side effects often lead to poor patient tolerance and adherence.
Yeah, that sounds unpleasant. Limits their appeal.
Definitely limits their widespread use, despite the unique mechanism.
Okay. Moving on to a much more commonly used and generally better tolerated class.
Yeah.
The dipeptidyl peptidase 4, DPP4 inhibitors. We've got litagliptin, linagliptin, saxagliptin, and sitagliptin. These are often called gliptins.
Right. These oral agents work by leveraging that same incretin system we discussed with the GLP-1 agonists, but they do it indirectly.
How so?
Remember how the natural incretin hormones, GLP-1 and GIP, are released from the gut after a meal to boost insulin secretion? Well, there's an enzyme in the body called DPP4 whose job is to rapidly break down and inactivate these incretin hormones, usually within minutes.
Okay, DPP4 is the off switch for incretins.
Exactly. So the DPP4 inhibitors, the gliptins, do just what their name says. They inhibit the DPP4 enzyme. By blocking this off switch, they effectively prolong the activity of the body's own naturally produced GLP-1 and GIP.
So they make your own incretins last longer and work harder.
Precisely. This leads to increased glucose-dependent insulin secretion and decreased glucagon secretion, similar to the effects of GLP-1 agonists, but achieved by preserving the endogenous hormones rather than mimicking them with an external drug.
Gotcha. Key attributes of this class. They're generally weight neutral.
Yes, unlike SUs or TZDs, they don't typically cause weight gain, which is an advantage. They're taken orally, usually once daily. And because they work by enhancing GLP-1 GIP action, it doesn't make sense mechanistically to combine them with a GLP-1 receptor agonist. You wouldn't use both together.
Right, targeting the same pathway. What about side effects or warnings? They seem pretty well tolerated overall.
Generally, they are well tolerated. Common side effects can include things like nasopharyngitis, common cold symptoms, and headache. However, there are some important safety signals to be aware of.
Such as?
Similar to GLP-1 agonists, there have been post-marketing reports of acute pancreatitis associated with DPP-4 inhibitors, so caution is advised, especially in patients with a history of pancreatitis. There have also been reports of severe and disabling joint pain, arthralgia, which may resolve upon stopping the drug.
Pancreatitis and joint pain risks. Anything else specific to certain drugs in the class?
Yes, this is important. Large cardiovascular outcomes trials for two specific DPP-4 inhibitors, elogliptin and saxagliptin, showed an unexpected increased risk of hospitalization for heart failure compared to placebo.
Increased heart failure hospitalizations, with those two specifically.
Yes, with elogliptin and saxagliptin. While other DPP-4 inhibitors like sitagliptin and linagliptin did not show this signal in their respective trials, it adds another layer of caution when choosing an agent, particularly for patients already at risk for heart failure. They join the TZDs on our list of drugs to be wary of in heart failure patients.
Okay, that's a critical distinction within the class.
Mm.
Any unique pharmacokinetic details we should know?
Yes, one really useful clinical pearl relates to kidney function. Most DPP-4 inhibitors, sitagliptin, saxagliptin, alogliptin, are primarily eliminated by the kidneys, meaning their dosage needs to be adjusted downwards in patients with renal dysfunction.
Okay, dose adjustment needed for most.
But linagliptin is unique. It is the only one that is primarily eliminated via bile and the gut, enterohepatic system, not the kidneys. Therefore, linagliptin is the sole DPP-4 inhibitor that requires no dosage adjustment, even in severe renal impairment or end-stage renal disease.
Wow, that makes linagliptin a very convenient option for patients with kidney disease.
It simplifies management significantly in that complex patient population. That's a key differentiator for linagliptin.
Great clinical takeaway. Okay, finally, let's discuss one of the newest and arguably most impactful oral classes, the sodium glucose cotransporter 2, SGLT2 inhibitors. Canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, the flozins.
Yes, these agents have really made waves, not just for glucose lowering, but for their cardiovascular and renal benefits. They work via a completely novel mechanism centered entirely on the kidney.
Okay, kidney-centric. How do they work?
The kidneys filter a large amount of glucose out of the blood every day, but then they normally reabsorb almost all of it back into the bloodstream to conserve energy. The primary protein responsible for this reabsorption in the proximal tubule of the kidney is the sodium glucose cotransporter 2, or SGLT2.
Okay, SGLT2 pulls glucose back into the body from the kidney filtrate.
Exactly. It's responsible for reabsorbing about 90% of the filtered glucose. So the SGLT2 inhibitors do precisely what their name implies. They inhibit the SGLT2 protein.
Blocking glucose reabsorption, so the glucose stays in the filtrate.
Yes. By blocking SGLT2, they prevent the kidneys from reclaiming that glucose, forcing it to be excreted out of the body in the urine. It's essentially glucosuria sugar in the urine induced pharmacologically. Think of it as the kidney being forced to waste glucose, regardless of the body's energy needs.
And that lowers blood glucose levels.
It does, effectively. And this mechanism is independent of insulin secretion or insulin sensitivity, which makes them effective at various stages of type 2 diabetes.
And this mechanism also leads to other physiological effects, right? Like the blood pressure reduction.
That's right. Because glucose is excreted in the urine, it pulls water along with it via osmosis. This leads to an osmotic diuresis, increased urine volume, and fluid loss. This fluid loss often contributes to a modest but noticeable reduction in systolic blood pressure, which can be beneficial.
And this fluid shift, and maybe other effects, are thought to underlie their major clinical benefits beyond just sugar lowering.
Yes, the exact mechanisms are still being fully elucidated. Theories involve shifts in cardiac fuel metabolism, improved vascular function, effects on kidney hemodynamics, but the benefits are substantial and proven in large trials.
Which benefits specifically?
Empagliflozin, canagliflozin, and dapagliflozin have all demonstrated significant reductions in major adverse cardiovascular events, MACE, in patients with type 2 diabetes and established cardiovascular disease. Empagliflozin was the first to gain a specific indication for reducing the risk of cardiovascular death in this population.
Wow, reducing CV death, that's huge.
Huge. Additionally, these agents, particularly empagliflozin, canagliflozin, and dapagliflozin, have shown remarkable benefits in slowing the progression of diabetic kidney disease and reducing hospitalization for heart failure, even in patients without diabetes in some trials for dapagliflozin and empagliflozin.
So cardiovascular protection, renal protection, heart failure benefits.
Mm-hmm.
This class offers a trifecta that few other oral agents can match.
Absolutely. It's revolutionized treatment guidelines, especially for patients with coexisting cardiovascular disease, kidney disease, or heart failure.
Okay, powerful benefits. But no drug is without side effects.
Mm-hmm.
What are the main concerns with SGLT2 inhibitors? Tied to the mechanism, I assume.
Directly tied to the glucosuria, yes. The most common side effects are genital mycotic infections, yeast infections, like candidiasis, which occur more frequently in both women and men because the sugary urine provides a growth medium for fungi. Urinary tract infections, UTIs, may also be slightly increased.
Okay, infections are common. What about the diuretic effect?
The osmotic diuresis can lead to volume depletion, potentially causing dizziness, orthostatic hypotension, low blood pressure upon standing, and dehydration, especially in the elderly, those on diuretics already, or those with impaired kidney function. So, assessing volume status and cautioning patients about hydration is important.
Hypotension risk. Any other serious, though maybe rarer risks?
Yes, a few important ones. There is a rare but serious risk of euglycemic diabetic ketoacidosis, DKA. This is unusual because DKA normally occurs with very high blood sugar, but with SGLT2 inhibitors, it can sometimes happen even when glucose levels are only moderately elevated or near normal.
Euglycemia DKI, that sounds tricky to diagnose.
It can be. Patients and clinicians need to be aware of DKA symptoms: nausea, vomiting, abdominal pain, fatigue, shortness of breath, even if blood sugar isn't sky high. Risk factors include major illness, surgery, severe caloric restriction, or excessive alcohol intake. Drugs should be stopped if DKA is suspected.
Okay, euglycemic DKA risk. Anything else?
There was an initial concern with canagliflozin specifically about an increased risk of lower limb amputation seen in some early trials. Although later data has been somewhat reassuring, the warning remains in some regions. There's also a potential risk of bone fractures with canagliflozin and possibly others. And of course, since their efficacy depends on kidney filtration, they become less effective and are generally not recommended or are contraindicated in patients with severe renal dysfunction, typically eGFR 30 or 45, depending on the specific agent and indication.
Okay, lots to consider there. Infections, volume depletion hypotension, the rare euglycemic DKA, potential fracture amputation risk, mainly CANA, and the need for adequate kidney function.
That covers the main points for SGLT2 inhibitors.
We should also briefly touch on those other agents mentioned in the sources, bromocriptine and colesevelam. Where do they fit in?
Yeah, these are less commonly used. Bromocriptine is a dopamine agonist, and its exact mechanism for lowering glucose isn't fully understood, but might involve resetting circadian rhythms in the hypothalamus. Colesevelam is a bile acid sequestrant, primarily used for cholesterol lowering, but it also has a modest glucose lowering effect, perhaps by modulating incretin release or glucose absorption.
But they're not major players.
Generally not. They produce only modest reductions in HbA1c compared to other classes. Bromocriptine can have side effects like nausea and dizziness. Colesevelam requires multiple large pills and can cause significant constipation and interfere with the absorption of other medications. So their use is often limited by relatively low efficacy, side effects, or high pill burden, typically reserved for very specific patient situations.
Okay, niche agents mostly. We've now covered 10 diverse pharmacological classes for type 2 diabetes, plus insulin and the other injectables. That is a massive amount of information.
It really is. The therapeutic landscape is complex.
So let's try to synthesize this now. How do professionals actually use this information in practice, applying all those detailed constraints we've spent this entire deep dive accumulating?
Well, the ADA guidelines provide a clear framework. As we said, metformin is almost always the preferred initial drug for type 2, assuming no contraindications and it's tolerated.
Right. Start with metformin.
The real art and science of medicine comes in if, after about 3 months of metformin plus lifestyle efforts, the patient's HbA1c remains above their individualized target. Often that benchmark of 7% is used, though it can vary.
Okay, so metformin isn't enough. Now what?
Now the clinician has to choose a second agent to add. And this choice is not random. It should be dictated almost entirely by considering the patient's specific clinical characteristics, comorbidities, risks, preferences, and cost.
This is where we absolutely have to apply that detailed knowledge to the clinical constraints, connecting all those warnings and benefits we just detailed to the specific patient sitting in front of you.
Exactly. It becomes a process of elimination and prioritization based on risk stratification.
Let's run through some critical pairings, like the source material suggests. If a patient presents with established heart failure, what gets ruled out immediately?
Immediately, you have to rule out the TZDs, pioglitazone, rosiglitazone, because of the significant risk of fluid retention worsening the heart failure. They are contraindicated in severe HF.
Okay, TZDs are out. What about others?
You'd also exercise caution or likely avoid the DPP-4 inhibitors, elagliptin and saxagliptin, given their documented link to increased hospitalization for heart failure.
Right, so HF significantly narrows the choices. Conversely, which classes might be preferred in heart failure?
The SGLT2 inhibitors, empagliflozin, epagliflozin, canagliflozin, have shown significant benefits in reducing heart failure hospitalizations, even becoming standard of care for HF in some cases, regardless of diabetes status. So they would be strongly considered here.
Okay, powerful preference for SGLT2s in HF. What if that same patient also has a history of chronic pancreatitis?
Now you have another layer of constraint. You must avoid both the GLP-1 receptor agonists and the DPP-4 inhibitors due to the associated, albeit debated, pancreatitis risk noted in their labeling.
So if a patient had both HF and pancreatitis history, the field of second-line agents gets really narrow really fast. Maybe just an SGLT2 inhibitor or perhaps basal insulin would be the main options left after metformin.
Exactly. This kind of risk-layering exercise is precisely what clinicians do. It quickly highlights the few suitable options remaining.
Let's take another common comorbidity, renal dysfunction. Chronic kidney disease,
Sure.
CKD. This requires massive caution, right?
Massive caution. First, metformin itself needs dose adjustment in moderate CKD, eGFR 30 for 45, and is contraindicated in severe CKD, eGFR 30, due to the lactic acidosis risk.
Okay, metformin out or reduced. What else?
The SGLT2 inhibitors become less effective at lowering glucose as eGFR declines and are generally contraindicated below an eGFR of 30 or 45, although they might be continued for their renal or cardiac benefits at lower eGFRs under specialist guidance in some cases.
Okay, SGLT2s likely out for glucose lowering in severe CKD. What about the secretagogues?
Here's where that critical distinction within the sulfonylureas comes back. Glyburide is high risk for prolonged severe hypoglycemia and renal impairment due to its active metabolites and should generally be avoided. Glipizide or gleampyride are considered significantly safer choices in CKD.
And the glianides.
Beta-glucanide requires caution. Repegalinide seems less affected by renal function but still needs care.
What about the DPP4s?
Most require dose reduction, SIDA, Saxa, Elo, but remember linagliptin requires no dose adjustment, making it a very useful option in CKD.
So in CKD, linagliptin, safer SUs like glyphosate, glympuride, or insulin become key considerations after metformin.
That's often the case, yes.
And finally, let's consider the factor of weight. Managing weight is crucial for managing insulin resistance itself. Which agents help or hurt here?
If weight loss is a major goal, or avoiding weight gain is important, then the GLP-1 receptor agonists and the SGLT2 inhibitors are highly preferable choices, as they're consistently associated with weight loss. Metformin is weight neutral or causes modest weight loss.
Okay, those are the weight-friendly options. Which ones cause weight gain?
The agents most consistently associated with weight gain are insulin, sulfonylureas, glianides, and thiazolidinediones, TZDs. DPP-4 inhibitors are generally weight neutral.
So if you have a patient who is overweight or obese, adding an SU, TZD, or even insulin might exacerbate that problem, whereas a GLP-1 or SGLT2 could help on two fronts, glucose and weight.
Precisely. It's another key factor in individualizing therapy.
So putting it all together, the professional synthesis requires constantly weighing the potential efficacy. How much will this drug lower HbA1c against at least 4 primary domains of risk or benefit? The risk of hypoglycemia, the impact on weight, specific organ-related contraindications, kidney, heart, pancreas, liver, and increasingly the potential for proven cardiovascular or renal protection.
You nailed it. It is a highly dynamic, multivariable optimization problem that genuinely requires this mastery-level detail of each drug class, its mechanism, benefits, risks, and place in therapy. There is no single right algorithm after metformin. It's about tailoring to the individual patient profile using all this information.
Well, this deep dive has certainly spanned the entire spectrum. We went from the role of glucokinase as the glucose sensor right inside the pancreatic beta cell, through all the engineered nuances of different insulin formulations and delivery methods, and then navigated across the complexities of, what was it, 10 unique pharmacological classes of oral agents, plus the adjunct injectables, hopefully providing you, the listener, with a really high-fidelity map of modern diabetes drug therapy.
Yeah, we covered a lot of ground. And if we connect all this detailed knowledge back to the biggest picture, the overarching trend, we really see this profound shift in the clinical focus for type 2 diabetes.
How so?
The goal is evolving. It's no longer solely about mitigating hyperglycemia, just getting the A1C down. It's increasingly about actively reducing the devastating long-term consequences, particularly catastrophic cardiovascular and renal events, using agents like the SGLT2 inhibitors and GLP-1 receptor agonists that have proven benefits in these areas.
That's a really important evolution in thinking.
It is, and it raises, I think, an important final question for you, the learner, to ponder. As these newer agents with proven cardioprotective and renoprotective benefits emerge and become more central, and yet foundational drugs like metformin remain crucial, how fundamentally will we redefine the overall management strategy for type 2 diabetes in the coming decade? Will we move past just chasing glucose control early on and actually prioritize cardiovascular and renal risk reduction much earlier, perhaps even as a primary goal right alongside glycemic control from the moment of diagnosis? How will that change the sequence and choice of therapies?